Okay, thank you for the opportunity to present today. About 20 years ago, when I was starting at CDC, I was working on my first health economics presentation, and my mentor was giving some advice to me. And he said, you remember, there's three types of people in the world: those who are good at math and those who aren't. And he said, make sure your presentation appeals to all three types. So I promise there'll be no equations in today's presentation. And I'll start off with my favorite cost-effectiveness study. This is one from The Onion that concluded that the cost of living outweighs the benefits. So this is the kind of thing people think about when they think about Economist, of just the dismal science and so forth. So I won't, in addition to not showing equations, I won't do too much about cost-effectiveness today either. So this slide shows the statement of tasks that you've been assigned. And I think obviously health economics can contribute to the part about the economic burden associated with STDs. But I think it can also help as you assess current public health strategies and programs to prevent and control STIs, as well as providing direction for future programs and policy. So what I want to do today is just briefly run through a list of things that I think the field of health economics can contribute to the report, starting with estimates of the burden of STIs. First off, there's two different types of economic burden estimates for STIs, prevalence costs and incidence costs. So prevalence costs for the cost of treating STIs and their sequelae in a given year, and incidence costs are the lifetime cost of treating infections that occur in a given year. There have been four main studies over the past 20 years or so of the direct medical cost burden of STIs in the U.S., starting with Siegel's publication in 1997. That was an estimate of the prevalence cost of STIs. The next three studies looked at incidence costs. And I don't think you should interpret these as trends because all the studies were very different, but I just wanted to let you know that there were these four studies available. Not much has been done in terms of productivity cost, but I wanted to show just the example for gonorrhea. The first set of bars shows the estimated lifetime direct medical costs per new infection for men in black and women in red. The middle set of bars shows the direct medical costs associated with treatment. So you might wonder why for men is the cost of treatment higher than the lifetime cost of infection. That's because for a lot of men, they don't actually ever get treated. They might be asymptomatic and the infection go away. So the lifetime medical cost estimate takes into account the probability of receiving treatment and the probability of sequelae. And then the final set of bars here shows the estimated productivity cost per case. And this is limited to a subset of patients who missed work for treatment. And for this particular subset, the productivity costs were in line with the direct medical treatment costs. So you can think of many components of the economic burden of STIs. As I mentioned, there's the direct medical costs associated with treating STIs. There's productivity costs such as foregone labor, missed work. There's also cost of STI prevention, which usually aren't included in these estimates, such as the cost of STI screening, HPV vaccination, and cost of preventing the adverse outcomes of STIs such as cervical cancer. And perhaps the biggest burden of all would be the intangible burden, the pain and suffering associated with STIs, behavior change to avoid STIs, stigma, as we mentioned earlier. There's just a whole lot of these costs that are very hard to quantify. And I think if you're trying to include all these costs, you can get a little bit carried away. And this is an example I used in a syphilis cost-effectiveness analysis. I came across this study that talked about how syphilis contributed to making William Shatner a star. And apparently, he was an understudy, and the actor above him was feeling too ill from the effects of syphilis to go on stage, and he performed instead and became a star. And I think in the cost-effectiveness analysis, if we take into account that had we prevented that case of syphilis, we'd have lost, you know, a multi-million-dollar Star Trek franchise. It can really distort things. So I think you want to consider a broad economic burden, but not get out of control. So in terms of the economic burden of STIs, what my recommendation would be, in terms of the direct medical cost burden, as I mentioned, there's published estimates available. Not only that, but we're in the midst now at the Division of STD Prevention of updating this. So we hope to have this done in 2020. So I think for you to do that, I think would be a duplication of efforts and not a good use of resources. I think instead you might want to focus on the other components I mentioned of the economic burden of STIs, such as the prevention cost and the intangible costs. The field of economics can also contribute to the report in terms of the analyses of the impact and cost effectiveness of STI prevention interventions. These are usually combined with STI transmission models. There's a lot of these out there. There are special issues devoted to this. There's reviews of the models behind these. There was recently a modeling paper that estimated the impact nationally of chlamydia screening over the last 15 years. And as Dr. Kalishma said in the previous presentation, I didn't know we had a meta-analysis of meta-analyses. So there's a lot of these reviews and evidence out there. So my guess would be that you're not going to undertake this type of meta-analysis or anything like that. But I think what you could do is make use of the summaries that have come ahead of you and maybe compile these summaries and fill in the gaps and point to where additional studies are needed. I think another interesting thing that economists have contributed to STI prevention is showing evidence of an association between STI prevention funding and reduced STI incidence. And I think this is a good thing. There's a lot of money allocated for STI prevention, and showing a link between the money spent and the desired outcome is a good thing. So this table summarizes 4 studies that examine the impact of prevention funding. The first 3 studies look at federal funding for STI prevention and show that greater amounts of prevention funding in a given year are associated with lower STI rates in subsequent years. And the study listed at the top was just published by one of our prevention effectiveness fellows, and it is a major update from the 2 studies underneath, in that it includes about 17 years of data, including fairly recent data. And then what's interesting about the study at the bottom is that this doesn't look specifically at STI prevention funding. It looks at county level public health funding and just shows that the public health funding was associated with reductions in STIs in California. So my recommendation for this issue is, I think it would be interesting if the report could highlight the existence of the evidence linking prevention funding to the desired outcomes, maybe note the strengths and weaknesses of this approach. And I think it would be interesting to talk about evidence for the population level impact of STI prevention, as well as the evidence of these more micro level, like the intervention level effects. Like we have evidence that a given intervention can affect behaviors, and we have some evidence of population level effects of STI prevention. And maybe if the report could discuss this spectrum of evidence. What is, to me, most interesting that economists have contributed to STIs is analyses of policies that can affect sexual behavior and STI incidence. And I did a review a few years ago called Sexonomics, where I talked about STD studies in the economics literature. And one of the key themes of these studies is that the cost of risky sex can affect the demand for risky sex. And there's a lot of these topics. Some of these were included in the review, and some have come since then. And I won't go through all of these today, but I will just go through a few of these: alcohol policy, same-sex marriage, and concentration of risky sexual behaviors. So one interesting thing, there's been several studies showing that alcohol taxes can actually have an impact on STI rates. Just the idea people, alcohol taxes reduce drinking, that can reduce risky sexual behavior. This was the subject of a debate a few years ago at our STD prevention conference. We had the yes and the no experts, and Bill Miller, who was arguing against it, took the approach of alcohol doesn't give people gonorrhea, people do. So he was saying, you know, this isn't reasonable, but he did concede that at least it was theoretically possible that the mechanism might work. So the person arguing yes, these things can have an effect, they said that there's well-established evidence that taxes reduce alcohol consumption, and it's well established that taxes reduce alcohol-related diseases and traffic accidents, so it's reasonable to conclude that alcohol taxes can prevent STIs. And he gave an interesting list of all of these health outcomes that have been shown to be reduced as a result of alcohol tax increases, including things directly related to consumption like liver cirrhosis and other things that are less directly related, such as robbery rates. Economists have also looked at same-sex marriage laws and syphilis rates, and Tom D. was the first one to do this back in 2008, and he used the changing legal status of same-sex relationships in European nations between 1989 and 2003. And he found that legal recognition of same-sex couples reduced syphilis rates among MSM. And then in the US, Francis and colleagues found evidence consistent with that. They kind of looked at the reverse effect. Rather than looking at legalization of marriage, they looked at the effects of same-sex marriage bans and found that these bans were harmful in terms of STI rates among MSM. As far as the distribution of STDs and concentration of risky sexual behaviors, these are Lorenz curves, and they're used often in economics to plot income inequality. But they've also been adapted to the field of STD prevention to show how STDs are distributed geographically, say across counties or things like that. This shows the county level distribution of 3 STDs. If every county had the same STD rate, then this line would look like that gray line of equality that shown in the diagonal there. And the further we get away from this line, the more unequal these STDs are distributed across counties. For example, syphilis is the most unequally distributed. You see it intercepts around the 0.5 mark. And at the time this was done, about 50% of counties had no syphilis. That's why the line is there. The 50% of the counties with the lowest syphilis accounted for 0% of syphilis cases. And I think what's interesting is people have gone beyond looking at the distribution of STDs to looking at the distribution of sexual behavior. And this is one that Jamie Licklider did, looking at the concentration of vaginal sex acts in the past month. And 5% of the population with the highest number of vaginal sex acts accounted for more acts than the 50% of the people with the lowest number of sex acts. So for example, if this were done for 100 people, the 5 most active people would have 135 acts, and the 50 least active people would have 45 sex acts. And this gets to the highest risk group. I guess experts here in STDs have heard about the core group idea. There's a group of highly active people called the core, without whom we might not be able to sustain transmission of rare STDs like syphilis and so forth. And one day at CDC, we were talking about why do we have a name for the riskiest people, but we don't have a name for the group of people at lowest risk? And somebody suggested that we call them the Gettysburg Address group, because their last 4 scores were 7 years ago. But that just, it never caught on. This is the health impact pyramid that former CDC director published a few years ago, showing the population level impact and the individual effort needed. And the cost effectiveness studies that have been done typically focus on the upper end of this pyramid. And what I wanted to just highlight was that the policy studies can focus more on these population level factors that can have an even bigger impact on STI rates. So in terms of these economic studies that address STIs, I think it would be interesting if the committee could take a look at some of these studies that have examined economic and other policies that affect sexual behavior and STI rates, and highlight any gaps in this literature or studies that need to be done. And finally, I'll talk a little bit about tools that can quantify the value of STI prevention activities. We've developed 2 tools at CDC, SPACE-Monkey and Stick-Figure. These are Excel-based tools. And what SPACE-Monkey does, and I'll explain that in just a minute, it helps STI prevention programs estimate the impact of changes in their budget in terms of the incidence of STIs and the cost of these STIs. And what Stick-Figure does is it allows these prevention programs to estimate the economic impact of their program activities in terms of direct medical costs averted. So they're both Excel-based. This is SPACE-Monkey. It's the STD Prevention Allocation Consequence Estimator. And what they do is they just go into the spreadsheet and they put in information about their budget and the burden of STDs in their area, and it estimates what the impact of changes in their funding would be. And it's based on the studies I showed earlier about the link between program funding and STD rates. And then Stick Figure, similarly, is an Excel-based program where all you have to do is enter in information about the number of people you've treated for various STDs and things like that, and it will estimate the number of cases you averted in terms of sequelae in that person, plus the population level impact of interrupting transmission to partners. So in terms of these tools, it might be interesting if the report could highlight these available tools and note the need for them to be updated because they're already getting out of date, and maybe propose additional tools that could help STI prevention programs, not only in terms of estimating the economic effects of their program, but just any kind of tools that could be of use to them. So I've talked about what economics can contribute to the report. So what I want to conclude with is just talking about what I think the report can contribute to our understanding of the economics of STI prevention. So I think, as I mentioned, it could give a focus on the economic burden of STIs besides or in addition to the direct medical cost. It can, to me, I think, be the most comprehensive and definitive compilation to date of the current state of evidence of the impact and cost effectiveness of STI prevention interventions, in addition to give recommendations for other studies that we need to do. And it can provide guidance on how we can assess the value of STI prevention and give us recommendations about how to make the business case for STI prevention. Let us know what type of impact measures that should be collected and what types of studies we should be doing to do that. And the other thing my mentor said was nobody ever complains if you end a little early. So with 3 minutes left on the clock, I will say thank you.
All right. Dr. Chesson, grab a seat. And we've already got I didn't notice the order, so forgive me. I'll just go clockwise here. Ned and then Patty.
Thank you, Harrell. I always learn a lot from you. I am interested in the distribution of funding for STI control within states and the mix of local funding versus federal funding. You made a point in an earlier slide that in California, at least, county level public health spending correlates with gonorrhea and syphilis rates. But I was wondering if anybody had done those sorts of analyses on a state-by-state or countywide basis for the nation. And then later on, you said SPACE-Monkey, you implied that might help to do that. So the part two of my question is, if SPACE-Monkey would do that, how widely is it used, and do you have any data regarding that?
To push this, yeah.
Okay. So I'm trying to figure out exactly what question you want me to answer. In terms of federal funding that goes to the states and to certain cities is determined by a formula now since, Gail could say since 2014, I think, where it's based on population and disease burden, whereas before it was based primarily on historical precedent. So we know how the federal funds follow a specific formula. What we don't know much about is state and local investment in STD prevention. There was the ASHA report that was done a few years ago that gave some evidence about that, and we're in the process now of trying to collect more information, but we really don't know much about how much money is devoted to STD prevention from non-federal sources.
Why not?
It's difficult. It's been difficult to measure, and like I said, we are currently funding studies to address that.
This is Gail Boland.
The data have, is this on?
Yeah, the data of funding from state and local programs has been challenging to get. There's concerns, at least by some of the people who've been asked, that it could point to some deficits in the work that they do, and they're afraid to share. And obviously, I think we're a little bit better off than HIV, because when HIV came along, the federal funds pretty much paid for all the programs. And so very little investment was made at the state and local level for HIV because it was covered with federal dollars. At least since the 40s, we've had a collaborative relationship with state and local programs and our federal dollars, and it's expected that the clinical service delivery and the sort of care of individuals is a responsibility of states and locals for their citizens. And our federal dollars are more for surveillance and surge capacity and disease kind of investigation. So we've had challenges. The NAPA report, part 2, was supposed to be getting some information in this area, and I've heard that maybe it's only going to be having some case studies. So we do know some states have cut all their state STD funding and have only, they're left with federal funding, and they are left with their healthcare system, whatever it looks like, providing the clinical services. So this is an area that we really feel is needed to better understand, what's the comprehensive nature of an STD program at a state level, because really our job at the federal level is to provide resources. It's up to the state to figure out what their needs are, and we give a very flexible plan, apply that to the needs of the context of the STI epidemic in their areas.
I mean, because it really, part of the purpose of this committee's work is to make recommendations regarding policy. And if you can't get the data to analyze policy, we got a big problem, right?
Right.
And can I ask you a quick follow-up, Sten, before she sits down? Just Gil, along the same lines, so you're saying you don't really know, state by state, county by county, what resources they have available, plus it's dynamic, because their legislatures are kind of changing. That's one point. But you also don't know about how much burden is being placed on the private sector of people who are going to emergency rooms and doctors' offices, whether they're trained properly or not. And so isn't it a continuum of not knowing?
Well, we have a little bit more in that area. We try to understand, at least of the cases reported to us, who the provider was. So we have some data on that, and we've been doing some assessment of how much is in urgent care, how much is in the emergency department, and it's not insignificant.
Do you not get don't the state health, where they exist, don't the counties and states also report disease likewise? Don't you have a parallel universe of state and county reporting?
We only get data from state and local health departments. We don't collect any data.
So the providers you can only get through if they have insurance.
Well, we ask our STD programs at the state level when they report a case to us to indicate the provider. It varies on how the data are collected. But we have some enhanced systems that we're trying to do better in that area. But the other problem is we also can't sort out how much, when you have a combined STD HIV program, which is very common now, when resources get small, people merge programs, how much is funded by HIV and how much is funded by STD. We've been trying to look into that. I will say we get org charts from everybody. We mandate that in the grants. So, but I can't figure out, person X, or they have combination funding from different programs, or are they just funded with STD, they just funded with HIV. So this is just an area that we've been working very hard on and are making some progress, but there's still huge gaps that I agree with you, Ned, for policy purposes are desperately needed. So we'd welcome some innovation of how we can better understand these resources, especially at the local level. We find the smaller you get, it's like the one public health nurse does everything. And if there's a rabies case, well, sorry, there's going to be no STD and HIV done that week. So it's very fluid and challenging.
Thank you so much for an educational and entertaining talk. I have a couple of different questions. First of all, the space monkey and the stick figure, what's the difference between the two? How can people access them, and have they been validated? That's one, and then I have another question.
Okay, what Space Monkey does is it allows the STI programs to estimate what would be the impact to them of a change in their budget in terms of a number of additional STI cases and the cost of those. What Stick Figure does is it allows them to enter in their program activities and estimate what has been the impact of what they've done in terms of treating people and their partners and so forth.
That's open access?
Right. The Space Monkey is available on the Division of STD Prevention website, and Stick Figure is available at the National Coalition of State STD Directors website.
Thank you. So my second question, completely unrelated, is when you're doing the cost effect, you said we shouldn't do that because you're all doing that. Are you including non-reportable diseases like Trichomonas vaginalis and others, Mycoplasma genitalium and things like that?
We are including trick, but the others are chlamydia, gonorrhea, hepatitis B, HPV, HIV, and HSV.
So a couple of questions. First, it's surprising that the existing evidence has just kind of focused on the direct medical cost of STIs and, say, ignored productivity or effects on quality of life, which I think would be pretty standard for other diseases. So I'm wondering, is that because the inputs are not there, like people haven't estimated the impact of STIs on missed days at work or productivity, and that's why that hasn't been put into a model? Or is it that those inputs are there, but we just need to kind of build a model?
Okay. First, let me clarify that the studies that I presented in terms of looking at the impact of on direct, like we've assessed the burden in terms of direct medical costs, but a lot of the cost effectiveness studies that I mentioned, they do look at quality of life effects. So they're usually estimated in terms of cost per quality adjusted life year gain and things like that. So we do include quality of life in estimating the cost effectiveness of prevention programs. But a lot of times when we estimate the burden, most of the requests that we get for that information, people are specifically requesting the direct medical cost burden, and that's why we have focused on that. As I mentioned, there is the one or two studies on productivity costs, but that is an area where we do need more data. We've estimated it, but it's not based on very much empirical data.
And going back to Stick Figure and Space Monkey, so is that the underlying kind of a model that generates these numbers? Is that based on just the association between STI funding and incidence, or is it like a more causal relationship, or it's based on evidence from trials of different interventions?
The Space Monkey tool that estimates the impact of changes in the budget, that's based on the studies I showed estimating like 15 years of the gonorrhea data at the state level, looking at what was the impact, looking at changes, the association between funding and reported gonorrhea. So that's based specifically on that association. The Stick Figure tool uses simple decision tree type models to look at the effect of treatment and other program activities.
Okay, last question, please.
Yes, thank you. So a large proportion of CDC STI dollars to the states are going to DIS programs. What do we know, or do you know, about sort of efficiencies and cost effectiveness of the DIS, you know, as an intervention? And has that been looked at? And so are there models out there that sort of seem to be, you know, more highly efficient than others are?
We would like to know a lot more about the value and cost effectiveness of DIS. And I think there's a lot of non-STI benefits to having DIS, such as responding to other public health emergencies as they might arise. It's helpful to have these people in the field. One thing we have done with DIS that I didn't clarify in terms of the Space Monkey tool, the Space Monkey tool uses two ways of estimating the impact. The first is using the historical association observed between funding and outcomes, but it also examines what would happen if the change in funding were applied directly to changing the number of DIS personnel. And it incorporates published estimates of the impact of DIS activities at the population level. The drawback to that is those studies are maybe 15 to 20 years old, and I haven't seen anything updated to show the impact at any level, let alone the population level, of the DIS activities.
Thank you.